So hello everyone, this is Sam from Aspire.MRCOG. I'm trying to cover this topic of cancer of vagina, FIGO Cancer Report 2021 update. It's an interesting topic and I'll be covering this especially from the point of view of Part 2 candidates. So let's get cracking. So first of all, the important things, I have highlighted these important things for you guys so you are able to focus better and probably remember things for your EMQs or SBAs. Okay, so diagnosis of primary vaginal cancer, this is rare. So primary vaginal cancer is rare. Okay, vaginal cancer itself is also, I think it's rare. Okay, and primary vaginal cancer is even more rare. Why do we say that? Because whatever cancers are seen in the vagina, mostly they are actually the secondary, either they are secondaries from cervix or from somewhere else, okay, in the genital tract. So diagnosis of primary vaginal cancer is rare, as most vaginal tumors are metastatic from another primary site, okay? And although this is more common in the post-menopausal women, they say that they are being seen increasingly in young women as well, especially in the countries with a high HIV prevalence, okay? So it's associated with HIV prevalence and also associated with persistence of high-risk HPV infection. So HIV and HPV both have been mentioned. This is important because if it comes in SBA and we haven't done in-depth or a thorough reading, we might feel confused whether it was HIV or HPV. So please remember, this is seen in countries with high HIV prevalence and is associated with persistence of high-risk HPV infection, okay? The emphasis they're saying should be primary prevention, and primary prevention is prophylactic HPV vaccination, okay? Once there's suspicion of primary vaginal cancer, biopsy must be done, okay? Should be confirmed with a biopsy. And staging is clinical. Imaging can be done to support, to find out more details about the dimensions of the tumor and their spread, but and the staging should stay as clinical, okay? If further details are found, like if the clinical staging is done and the imaging would show that it's bigger or more, or deeper or something, they still say that you stick to the staging which was done clinical, okay? And treatment should be individualized based on the histologic subtype, and these should be referred to centers of excellence. Because centers of excellence, because these are not very common tumors, not very common cancers, so they require management in centers of excellence. Then introduction, we come to the introduction. So they say that primary vaginal cancer is rare, constituting 1 to 2% only, okay, of all the female genital tract malignancies. Primary ones, not all the vaginal cancers. Primary are 1 to 2% of all genital tract malignancies, okay? And only 10% of all vaginal malignant neoplasms. So if what we are saying is all with female genital tract malignancies, primary vaginal cancers constitute only 1 to 2% of those, okay? And out of all the vaginal tumors, primary constitute 10% of that, okay? It's strictly defined as a cancer found in vagina without clinical or histologic evidence of cervical or vulval cancer, okay? Or a prior history of these cancers in 5 years. So if there was a cancer of vulva in the last 5 years or cervix, and this now saw something in the vagina, the growth or cancer in the vagina, they'll consider this as an, as relapse of this one, the vulval or the cervical, okay, rather than primary vaginal. The primary vaginal is that rare, Okay, so historically, they say that these are common in the elderly, and as we said, they're now seen in the younger women as well, and related to HPV infections and HPV infections. So, which means that HPV vaccination is very important. Okay. So identification of small malignant lesions in the vagina is not very easy, really. Proper examination is can also be difficult. This is because of the anatomy of the vagina in the women. Its size varies with the parity, hormonal status, and the examination is not. It's not always easy to identify small lesions. Okay, primary prevention is by vaccination. HPV vaccination. Okay, so it's very similar to cervical, and the etiology is similar to the cervical cancer as well. So primary prevention is vaccination against HPV. Okay, so subtype 16 has been related to, it's important in the case of vaginal cancers. Now, secondary prevention, they're saying that if a woman undergoes a hysterectomy for for benign lesions, then they don't require long-term screening for vaginal cancer. But if the hysterectomy was done for some persistent high-grade squamous intraepithelial lesion, then pulse smears and colposcopy will be recommended, okay, as a part of the long-term follow-up. And then remember that in the cases where screening for vaginal cancer is indicated, then HPV tests are adequate. Like, you don't have to. They correlate well with the cytological findings. So you can depend on the HPV testing. Okay, tertiary prevention. So here under tertiary prevention, they've mentioned a few important things that you may need to remember, that cofactors including immunosuppression and cigarette smoking are related to this cancer as well, vaginal cancer as well. Okay, smoking in combination with the high-risk HPV, it increases the risk of progression to vaginal high-grade squamous intraepithelial neoplasia. Okay, so intraepithelial lesion, they call it. So the previous classification has been changed. Previously, it was called as vein vaginal intraepithelial neoplasia, vein 1, 2, 3. But now they have replaced it with low-grade or high-grade, LSIL or HSIL lesions. So vein 1 will be LSIL, and vein 2 and 3 are now HSIL. So here I've kind of made a little summary. Okay, so then let's go to the management. Okay, so progression, this is important as well, again, for your SBA kind of questions, that progression to HSIL, of HSIL to invasive cancer has been found in 2 to 12% of the cases. So 2 to 12% HSIL will progress to invasive cancer. Okay, and then treatment of precancerous lesions of the vagina must be individualized. If biopsy proven LSIL lesions are seen, they can be followed up with only observation. Okay, repeat smears and colposcopy, just like we do in CIN1 as well. Okay, so they can be just observed and without any active intervention. Okay, and especially if they have non-oncogenic strains of HPV. Other various modalities of the treatment include laser ablation, surgical excision, topical treatment such as imicamod, and topical chemotherapy with 5-FU. Okay, and of course the choice of treatment will depend on various factors. And for your, they probably ask you a few important things that we'll discuss here, but I don't think you need to know lots of nitty-gritty about this. Okay, so surgical excision, advantage is that it provides a pathological, just like, remember CIN, when we are worried that there is, there may be some invasive cancer, microinvasion, then we want to always have a biopsy specimen. Okay, so surgical advantage of the surgical removal would be we'll have a pathological description. Okay, then surgery will have higher morbidity, of course, if the lesion is near the bladder or the rectum. Okay, and it can cause dyspareunia as a result of vaginal shortening and stenosis. So these will be important when considering surgery in these patients, okay, with the HSIL. Then carbon dioxide laser vaporization is an alternative to excision. And especially if they're multifocal and you can't remove all of them, you remember that carbon dioxide laser vaporization can be used, okay? But of course, it doesn't give you any histological specimen. That's the downside of it. So remember, okay? So multiple lesions, carbon dioxide laser vaporization, yes, but no specimen will be obtained, okay? So that's why before doing this treatment, it's important that we don't have concerns regarding cancer here, no concerns regarding invasion. We are kind of sure that this is only precancerous stage, okay? Then topical F5FU, this can be used as milder and kind of a longer treatment, okay? And we can say that they found that laser and excision was superior to the topical management with 5FU, okay? So laser was more effective than excision in reducing recurrences of multifocal lesions. So when it was multifocal lesions, then laser was better, okay? Surgical excision is preferable with unifocal lesions, okay? Then imicomod, we're saying that this is an immune response modulator. Alternative and safe methods for treating women with, vaginal HSIL, and they only have few studies. It's safe and effective, and regression rates are similar to laser, and HPV clearance rates were greater than 50%. So this was HPV clearance rate with imicomod were greater compared to laser, okay? Then this could be like these kind of questions. They can sometimes, I mean, I'd feel personally that it probably will be a bit unfair, but to be honest, they can give you these kind of questions. Not that I'm fond of this or I think this is justifiable, but yeah, they can, okay, for SBS. It just depends on who is, I think various people make various level of complexity or of the exam, or sometimes it just can't be even justified. They can sometimes ask very strange questions, okay? So please be ready. Then management of invasive cancer of vagina. We'll come to this. And and before I come to the invasive cancer, I just wanted to highlight this thing as well, that when we were treating precancerous lesions, we need to remember that whatever therapy we choose, patients may require more than one therapy for adequate control of the condition, okay? So because recurrence rate is high, they say, with any single therapy, and close follow-up will be required, okay? HPV testing and cytology both are recommended for the follow-up. Okay, so management of invasive cancer, women usually present CA vagina usually presents with bleeding and smelly discharge. Okay, locally advanced disease may also result in pain and symptoms of disseminated disease depending on the site of METs. Okay, a diagnosis is made with a directed biopsy, and we have to make sure that there's no evidence of tumor on cervix or vulva, because if we find a tumor there, then our diagnosis will shift. We won't consider that as vaginal cancer then, because primary vaginal, as we said, is very, very rare. Okay, so biopsy can be done in outpatient setting, but they say that because you have to do a thorough examination, it's better to get the patient sedated or so that you can, yes, sedation or examination under anesthesia. Okay, so that a thorough examination can be done. As we said, it's not very easy to pick up small lesions in the vagina, so it's important that we have good pain relief rather than just a local anesthesia. As primary vaginal cancer is rare, treatment is complex, often individualized. Much of the management is, they've kind of tried to extrapolate the management that they were using for cervical cancer treatment. Okay. It's therefore recommended that these patients are treated in the, referred to a tertiary unit wherever possible. Okay. So patterns of spread are direct extension as well as hematogenous and lymphatic spread. Okay, so most tumors occur in the upper third of the vagina, especially in the posterior wall. This is an important question. It's like, I think this is like an SBA type question. Okay, that most of the tumors will occur in the upper third of the vagina, and especially in the posterior wall. Okay, so direct extension, of course, can be, to the tissue around the vagina, paravaginal tissue, parametra, and urethra, bladder, rectum. Okay. Sorry, the lymphatic spread, they say, can the upper vaginal tumors can go to pelvic lymph nodes, and including the obturator, internal iliac, and the external iliac lymph nodes. Para-aortic, this is rare para-aortic spread. Okay, lower part of the vagina that will drain to the inguinal or the femoral lymph nodes. Okay, and mid-vagina can drain in both the directions. Hematogenous spread is late. Okay, so dissemination to liver and lung and bone, they're usually late manifestations. Okay. So histologic subtypes. So just like we said for cervical cancer, the primary subtype is squamous. Okay, that's 90% of the cases. Adenocarcinoma is only in 8 to 10% of the cases. Okay, and the rest of them are rare, extremely rare, like lymphomas, sarcomas, melanomas. Okay. We are again saying that, remember that 80% of the cases would be metastatic or secondary tumors anyway. And they say that, okay, this is important. They say that I think this can come as an EMQ as well, that they could have given the description of some tumors and we will have to tell what, what tumor it is or what's the staging. So by definition, they say the tumors in the vagina that touch or they extend to the external os of the cervix, they should be classified as cervical cancers. Okay, not vaginal cancers. If they're reaching the external os, cervical cancers. Okay. So I was just wondering, if they're not reaching external os, but they are on the vagina and on the active cervix, that would be interesting to find out what that is, but they have not mentioned it here. So only if they're saying that if they are re-extending to the external os, then they are cervical cancer. Okay. Grading, grade X can't be assessed when grade can't be assessed. Okay, when you're not sure what grade to give, you write GX. Okay, grade 1 is well differentiated, 2 is moderately differentiated, 3 is poorly differentiated or undifferentiated. Okay, staging, as we said, that is the clinical staging. So I will not go through this staging table because this is quite going to be, I'll try to quickly superficially go through this, but this is going to be a good rote memory that you guys will need to do. Okay, I think try to draw a diagram and then try to go through this. Okay, so clinical staging can get help from imaging techniques such as CT, MRI. So stages are 1A, 1B, 2A, 2B, 3, and then 4A, 4B. So 3 doesn't really have a 3A, 3B. Rest of the stages have an A and B. So that's easy to remember. Only 3 doesn't have an A and B. All others have got A and B and no further subdivision. Okay, so 1A, the cancer is only in the vagina, no longer than 2 centimeters. It's not spread to nearby lymph nodes or to distant sites. Okay. So 1B is cancer is only in the vagina and is larger than 2 centimeters. So the first one was not larger. B is larger than 2 centimeters and again not spread to local lymph nodes or distant sites. Okay. 2A is the cancer has grown through the vaginal wall, but not as far as the pelvic wall, and no larger than 2 centimeters. So 2A again is smaller than 2 centimeters, and 2B is larger than 2 centimeters. But this one, what's the difference then? The difference is that they have grown through the vaginal wall. Okay. A smaller one will stay as A, and larger than 2 centimeter will be B. Okay. 3 is cancer can be any size and might be growing into the pelvic wall and or into the lower third of the vagina, and or has blocked the flow of urine. So this is just like 3B of the cervical cancer. Okay. Reaching the pelvic wall, lower third of vagina, blocking the flow of urine, causing hydronephrosis, causing kidney problems. Okay. It has also spread to nearby lymph nodes, but not distant mets. Okay. So what's happening is stage 3, that size, any size, and you remember the 3B of the cervical cancer, and just go along with that. That is spreading to the pelvic wall, side wall, pressing on the ureter, causing hydronephrosis and kidney problems, and maybe involving the lower third of the vagina. Now, or they are saying this, it could be this, or it could be growing into the pelvic wall and or going into the lower third of the vagina, block the flow of the urine, okay, and causing kidney problems. So not spread to the lymph nodes or to the, okay, so in the above one, it had spread to the lymph nodes, and here they're saying not spread to the lymph nodes, but still this is 3. But this classification of stage TNM classification, they're showing TNM classification here as well, that what it will be based on TNM. Okay, so now 4A is cancer is grown into the bladder or the rectum. Okay, so this was grown into the 3 was grown through the actually 2 was grown through the vaginal wall, then 3 was reaching the pelvic side wall, the 4 is now into the bladder or the rectum. Okay, or it's growing out of the pelvis. Okay, it may or may not have spread to the lymph nodes. Okay, and still there are no distant metastasis in 4A. Okay, no spread to distant mets. And now what's the difference here in 4B? The cancer has spread to the distant organs such as the lungs or the bones. Okay, so when the spread was to the bladder or the rectum, it was 4A. And when it's to the lungs and the bones, it's 4B. Okay. So that's it really. Now we'll quickly go to MRI. They say just use it like you do in cervical cancers. And MRI is more sensitive in detecting tumor size and paravaginal and parametrial involvement. So do remember that this can also be like an EMQ asking you to pick up, an investigation and imaging, okay, or it can be an SPA. PET-CT, as in cervical cancer, the use of PET-CT in primary vaginal cancer is superior compared with other imaging modalities, okay, for detecting nodal disease, okay, and it's also useful in detecting recurrent disease, okay. Then treatment of carcinoma of the vagina depends on so basically treatment depends on so many things. What's the histology and the tumor volume and anatomical localization, stage and age of the patient, okay, stage of the disease, age of the patient. So considering whether they want still require their reproductive potential or not, and the sexual function, okay, because that will be affected as well by various modalities. So different modalities can be offered. They can be combined as well, like surgery, radiation, chemotherapy, or a combination of these, okay. Surgery, the role of surgery is limited in primary vaginal cancer since the primary tumor is very close to bladder, urethra, and rectum. Okay. Surgical, in general, they say that primary treatment with surgery is limited to early and small lesions confined to the vaginal mucosa and less than 2 centimeters, not for the lesions that have gone through. So it's basically stage 1, not 2, where it has gone through the vaginal mucosa. Okay. So surgical management of stage 1 disease, they're saying early disease, upper vaginal disease, and lower vaginal disease. The treatment is slightly different, okay? Quite different, basically. So in upper vaginal disease, tumor is limited to the mucosa in stage 1 disease, and the uterus, if it's in C2, then you will remove it, okay? Radical hysterectomy, vaginectomy, aiming for 1 centimeter disease-free margins, okay? To be removed, of course, yeah, and pelvic lymphadenectomy. This should be offered. So when she has her uterus, offer to remove it, do vaginectomy, and including 1 centimeter disease-free margins and pelvic lymph adenectomy should be offered. Okay, and then they've written pelvic lymphadenopathy should be offered, but lymphadenectomy should be offered. So this is a typo on their behalf. So if the uterus has been removed, they say, then of course uterus is already gone. So offered vaginectomy and pelvic lymphadenectomy. Okay. Again, they've written pelvic lymphadenopathy can be performed. So, okay, they've done hard work, and people do get a bit tired when doing so much hard work. So this is forgivable. Okay, so lower vaginal disease, you don't need to touch the uterus in lower vaginal disease. Just do a radical wide local excision with 1 centimeter margin, and in addition, bilateral groin node dissection. So see, there was a pelvic lymphadenectomy in the above one, and vaginectomy and radical hysterectomy, 3 things, okay? And here is wide local excision with 1 centimeter margin and bilateral groin node dissection, okay? Other thing that you can consider in these women, especially in the young women, is ovarian transposition during surgery and pre-radiation. So move this ovaries out of the way, okay, even for the surgery or for radiation. So for central recurrence after radiation treatment, they say that if there's central recurrence, then pelvic exantration is a possibility. But of course, this is a massive undertaking, and that's why it's got a very huge impact on the quality of life and the body image. So extensive counseling is required. Okay. Palliative management of the recurrent or advanced disease. In this, they say that we can, if the woman has advanced stage 4 disease or recurrent disease with vesicovaginal or rectovaginal fistula, then palliative urinary diversion or colostomy can be offered to improve the quality of life before definitive management with radiation is done. So because if you started radiation first, then she will start suffering on that aspect as well. So offer the diversion before, and then you can offer the radiotherapy. And radiotherapy can be IMRT or EBRT. So you can, go through. I think they've given the details later somewhere. Okay, so use of brachytherapy is associated with longer overall survival, and they are doing image-guided or adaptive brachytherapy with CT or MRI, and it offers potential to give higher doses of radiation to the residual tumor, and without affecting the surrounding healthy organs that much. Okay, so doses higher than 70 gray units result in significant grade 3 or grade 4 toxicities. That's why the optimal or the lower threshold dose is 70 grays. And then concurrent chemotherapy with radiation. Modern management of vaginal cancer combines concurrent chemotherapies such as cisplatin or 5-FU along with the radiation. Okay, so they've given the details of the cycle. I don't think we, I don't think they'll ask you these kind of questions in depth, but you can have a quick read if you think they will. Yes, they have mentioned the disease-free survival here. Okay. And they said it was a small review study in which they found that a significant difference between overall survival and disease-free survival when comparing women who receive radiation alone versus combined radio and chemo, okay, as primary treatment. So overall survival was 3-year overall survival was 56% versus 79%, and 3-year disease-free survival was 43% versus 73%. Combination EBRT and brachytherapy to a total dose of 70 to 80 gray units with concomitant weekly cisplatin-based chemotherapy is the current standard of care for locally advanced vaginal cancer. So this is something important. So I will highlight this part as well. Okay, so then we come to the adenocarcinoma of the vagina. Only 8 to 10% of the cases are adenocarcinomas. Okay, they are related to desk exposure mostly, and they are saying that if the woman, if she's a desk daughter, then she should be screened closely with mammography for slight increase in the risk, of breast cancer. And non-desk is exceptionally rare. It behaves as a different entity, different natural history. Okay. Treatment, most adenocarcinomas are treated in the same manner as squamous carcinomas. Melanoma, they're saying this exceptionally rare and typically diagnosed in older women. Okay, incidence is approximately 3 per 10 million women per year. Okay, vaginal melanoma. So treatment, there's no standard treatment in the literature owing to the fact that it's very rare. Okay, and surgical excision either by wide local excision or colpectomy with or without pelvic exentration has been described. So surgical excision, either wide local excision or colpectomy with or without pelvic exentration. Okay. Adjuvant treatment in the form of radiation or chemotherapy or interferons can be considered. Okay, but limited evidence. Then sarcoma botryoides, rhabdomyosarcomas sarcomas are the most common soft tissue cancers in children and adolescents. 4 to 6% of all the malignancies in this group. Okay, 20% of these occur in the lower genital tract, and more than 50% are of embryonal histologic subtype. Okay, so what we are saying, rhabdomyosarcomas, they are most common soft tissue cancers in children and adolescents, and they account for 4 to 6% of all malignancies in this age group. Out of these, 20% occur in the lower genital tract, and more than 50% are of embryonal histology. Okay, and then they can be typical. So WHO classification of tumors of soft and bone stratified rhabdomyosarcomas, they have 4 main histologic subtypes. They can be typical embryonal variant or spindle cell sclerosing variant or alveolar variant or pleomorphic variant. I don't think we need to remember this, please. Okay, most rhabdomyosarcomas in children are in the vagina, whereas adolescents have predominantly cervical lesions. Okay, children have rhabdomyosarcomas in the vagina. Adolescents predominantly have cervical lesions. Sarcoma botryoides often presents in the first few years of life with bleeding and nodular lesions, filling and possibly protruding from the vagina, grape-like masses. So this was an exam question for part 2. Okay, bleeding, nodular lesions, possibly protruding from the vagina. This was a part 2 question with the differential in the list. Differential option in the list was foreign body. So, and I think I marked this as the same. Sarcoma botryoides. Okay, so more advanced stages of the disease may present with abdominal pain, abdominal mass or symptoms of distant meds. Okay, so usually they're saying bleeding and nodular lesions protruding from the vagina like grape-like. Okay, and in the first few years of life. Okay, and if the disease is advanced, then it will go up like abdominal pain, abdominal mass. Okay, treatment. These tumors are rare, and the treatment is based on the case reports only. So basically, they should be referred to the centers of excellence. Okay, they'll be giving them appropriate treatment there. If previously they used to do extensive surgery, but their extensive surgeries got very high morbidity. Okay, and now wide local excision and chemotherapy have been used with good success rates. Okay, so okay, so wide local excision and chemotherapy, good success rates. Okay, and the unfavorable risk factors are if the cervix is the primary site or the lesion is large, and the extent of the disease may require radical surgical intervention or chemotherapy. Okay, so if there are unfavorable factors, then wide local excision and chemotherapy will not be a better option. But otherwise, in the absence of these factors, and wide local excision and chemo will be good. Neoadjuvant chemo is another primary choice that can be used. Okay, so first neoadjuvant chemo and then do a surgical resection. Radiotherapy should be avoided. Young, very young adolescents and young patients, they will have long-term consequences. That's why in these patients, radiotherapy should be avoided. They compare them with the elderly kind of ladies who have vaginal cancers. Their problems will not be like uh, and the sexual activity will not be like the young ones. So the young ones will suffer much more because all their life is ahead of them, and the sexual activity and everything that will cause lots of morbidity. Prognosis and outcomes of vaginal cancer. The main determinant of the prognosis is stage of the disease. Okay, and whatever histology, stage of the disease at the time of diagnosis is important determinant. Additional factors are squamous subtype of the additional factors influencing prognosis in the squamous subtype are the tumor volume, stage, and then volume is location outside the upper third of the vagina, HPV status, and MIB1 index. Okay, then however the non-negotiable premises to so they are saying that the management options are different, but you will, of course, the MDT will give the best option that's best in terms of survival. Okay, because it's so rare, most of the data is not from like big RCTs. Okay. One of the study reported 5 years disease specific survival rate of 85%. But, this is just like one of the study or two of the studies. And I think it will be unfair if this kind of thing comes in exam. In the terms of prognosis for other histologies, young women with an early stage DES-related adenocarcinomas treated with radiation or surgery or multimodal approach have good outcomes with reported 5-year survival rate of 80 to 87%. Okay, young women, early stage DES, they are treated with multimodal approach and their survival, 5-year survival is 80 to 87%. And non-DES related, on the other hand, have a worse prognosis. Okay. As bad as, 5-year survival of 34%. Then what else is important here? Vaginal melanoma is a poor prognosis. 5-year survival rate is only 15%. So this is, this can be kind of an SBA or a question. Vaginal melanoma has a very poor prognosis. Okay. Okay. So finally, sarcoma botryoides, they say most of the available information comes from small reports and all that. And what are they saying? I don't see any figures here really. They are saying about sarcoma boituitis that use of radical surgery didn't confer a survival benefit compared with the local tumor excision. This is for sarcoma boituitis as well, okay? Radical surgery did not confer a survival benefit here. And yeah, I don't find any. Okay, so the survival rate of rhabdomyosarcomas has been mentioned, okay? It was only from a survey in 2017 of a small survey, 144 cases. 75.7% corresponding to embryonal subtype, estimated 5-year overall survival was 68.4%. So they are themselves too vague, too unsure. So they shouldn't be asking this question in the exam, hopefully. Okay. So I hope this has helped at all. I think if you try to listen to it once or twice, it should probably make some sense when you're on your go. You know, you could probably make use of your time. Let me know if it's not very helpful, then I'm not going to cover these topics. But if it's helpful, then I'd like to cover more of these topics, okay? As much as I can find time, really. Okay, I hope I'll find more time after the Ramadan because at the moment I'm fasting and I'm trying to speak. Okay, so goodbye and take care. Okay, bye-bye.